Hi, welcome to Long Island Naturally. I'm Mary Musi. For most people suffering with chronic and debilitating knee and hip pain, the answer is nearly automatic. Surgery is the only option they're aware of, but it's not the only option. My guest is Yass, a physical therapist from Farmingdale and the author of Overpowering Pain, the strength training program that stops pain without drugs and surgery. Also joining me is Joy Petrera from North Massapequa and Eleanor Mollison of Southampton. Both these women were told they needed a knee replacement. Both have since decided they don't need one after all. Thank you for joining me. Joy, let me start with you. You were told by 3 surgeons that you needed a joint replacement. What evidence did they give you?
Well, I injured my knee at work many years ago, and I began to limp and drag my leg. And my son is an orthopedic surgeon, and he sent me to big doctors in New York, and I got the same answer from everyone. I finally started seeing Yass when I developed ankle pain, and it was because I was dragging my right leg, and I was putting too much stress on the left leg.
Was there any physical evidence? Was there an x-ray of some sort?
Oh yes, I've had many x-rays, yeah, out in Long Island, down in New York.
What did they show, though?
The same thing, you know, bone on bone, but I always had full range of motion.
So, Mitch, I hear this all the time, and I'm sure you do too, that people are told they have a bone-on-bone condition, which I guess means the loss of cartilage, right?
Yep.
So how is it she was able to forgo surgery if she indeed had bone-on-bone?
Joy brings up the most critical evidence that you want to look at when determining whether someone's bone-on-bone, and that is range of motion of the joint. What typically happens is an x-ray is performed and they see that there's a decrease in the amount of cartilage between the 2 bones of the knee, and they assume that that means they're bone-on-bone. But if you were bone-on-bone, it would mean there'd be no joint space between the bones, and therefore you wouldn't be able to move the joint. As Joy mentioned, she had always had full range of motion, therefore it's impossible to make the diagnosis of bone-on-bone. And that's why we automatically, through looking at her clinically, recognize the cause of her problems could not have come from that diagnosis.
So why are people getting this diagnosis that there's bone-on-bone when indeed you say there still is some cartilage there, right?
Because the typical physician simply looks at diagnostic tests like x-rays or MRIs. They're not looking at them clinically. No one's really evaluating the joint. They're simply seeing the decreased range of the decreased joint space and saying, well, that means they need a knee replacement or a hip replacement, when in fact in 90% of the cases I've treated, there was never a need for the joint replacement.
Okay, well, Joy, tell me, what did your son, the orthopedic surgeon, say when you told him you were going to a physical therapist?
Well, at first he was, you need the surgery, and I said to him, okay, you do it. You do it, I'll come down to Maryland and I'll have the surgery. And he agreed. And then things in the family changed and we had other things to worry about, and my son met Mitchell and he thought his ideas were wonderful. He read the book, and he sees that I'm improving. His wife is an occupational therapist, and she sees it too.
Oh,
so
that's interesting.
I love it. I would never do without it, truthfully.
Okay, so Mitch, how is someone in Joy's condition able to improve? What kind of exercise do you give them exactly?
Joy's case was actually really interesting because when we first met her, she was walking with a cane, and her pain was actually at her left ankle and Achilles tendon. It was not at the right knee. What we recognized was that there was such extreme weakness of the right leg because no one was addressing it as a muscular problem, and she didn't want to get that knee replacement, rightly so. So what we did was we started establishing which muscles were weak in her right leg and began to strengthen them. We did front thigh quad work, hamstring work, and generally strengthened that leg. And actually, we never really worked on strengthening the left leg where her symptom was. As we strengthened her right leg, the pain at the left leg simply went away, because that was really what the deficit was, an inability to weight bear on the right leg due to weakness.
So you're saying the issue here is that people have weak muscles, and if they strengthen their muscles, somehow that supports the joint? Is that what you're saying?
Absolutely. Absolutely. What I'm saying is that although there has been a decrease in cartilage, that is not causing a symptom. The body has addressed it and has responded by healing itself, and ultimately the cause of pain is due to some sort of muscle weakness or imbalance causing a misalignment of the joint surfaces. That's why they rub excessively. That's why they get pain. So the only true resolution is to strengthen appropriately to achieve muscle balance and strength.
But don't some people who have these kinds of issues exercise as a routine anyway, and yet they're not finding pain relief?
Right.
What's different about what you do?
What it really comes down to is that you have to do a clinical evaluation and establish, is in fact the lost cartilage causing the symptom of pain, and the true indication of that has to be some severe loss of range of motion. In those cases, by all means, if in fact the cause was found to be the lost cartilage, they need a knee replacement, and I have sent people for knee and hip replacements. But what I've established over my 15 years is that that's maybe 2% of the population having knee and hip pain. Those other people are just muscle imbalances or weaknesses causing misalignment of joint surfaces that are easily resolved through strength training.
Eleanor, I understand you traveled all the way from Southampton to be here. Why was it so important for you to come?
Well, because I'm healthier, and I knew that Mitch's approach was the right one, and that is he took each patient individually and found out what was wrong or how what the problem was, and then he handles it individually. Whereas everywhere else I've gone, they've all said the same.
Now I understand you had a torn meniscus because you had an accident, and you had an operation, but
Yes.
then you still had pain afterwards, is that right?
That is correct, and I've had it for 11 years.
And you just found Mitch in December, I understand.
Yes.
And so what have you been doing since then that's made the difference?
I've been going to Mitch, and his crew has healed me. The first time I was on the table, he manipulated my muscles, and then he asked me to get off the table, and I had no pain, and I started to cry.
Oh my God, that is a dramatic story.
And it's been that
Wow.
way ever since.
So how often do you see Mitch now?
Twice a week.
And you travel all the way from Southampton to do that, to Farmingdale? Wow.
I would go anywhere to see him.
Is there any improvement in anyone's, is an osteoporosis a fact here that, do you find that people have improved bone density? Has that happened to anyone?
Yes, I did. I went for a bone density last year, and they compared it to the year before, and they said they never saw anything like it. So I asked for a copy, and I went directly to Mitch to bring it to him, because they said, "What are you doing? Are you taking any different drugs?" I said, "I'm doing nothing." I said, "Strength training, weight-bearing exercises," which I've heard would improve, because I was on osteopenia on the borderline, and they saw an improvement.
Okay, Mitch, I know that some people do eventually get referred for surgery. Are there some cases you can't help?
Yes,
do you-
as I said, the key to establishing who needs surgery and who doesn't is based on a clinical evaluation, not an X-ray or an MRI. Enough studies have shown that as many people with no pain can be found to have herniated discs, arthritis, stenosis, meniscal tears, rotator cuff tears, all of these things, almost in the same percentage as those with pain. Therefore, the conclusions of the studies have been that these tests are considered to be invalid, and therefore to use those as the mechanism for establishing surgery is just a false premise, and it can be seen in the number of failed surgeries being performed. So a clinical evaluation is necessary, and I've treated roughly 13,000 people, and I've established that maybe 2 to 3% of them do require surgery, and I fully endorse the surgery, have them go for surgery, and treat them post-surgically.
Of course, you work with people with back problems as well. We're just focusing on knee and hip pain in this segment. So tell me, Mitch, why don't other physical therapists do what you do?
Because whether it's a physical therapist, a chiropractor, or a physician, they base their practice on the way they're educated. And the basic medical establishment continues to promote the idea that the cause of pain can be established through X-rays and MRIs, and both through the studies that have come out and the huge amount of empirical data I have with the 13,000 patients I've treated, have recognized that there is no correlation between those findings found on X-rays and MRIs and pain. And therefore, the only way to establish the true cause is through a clinical evaluation. You then have to accept the idea that in most cases the cause is muscular, and then you have to accept the idea the only way to resolve those is through strength training. So that's how the premise began, and I followed it ever through for my 15 years.
Thank you so much for joining me, and thank you for watching. Tune in each Monday for my reports on natural health and alternative medicine. I'm Mary Musey for Long Island Naturally.